So this is Dr. Urmila Anand for you. She's a nephrologist who from the Glaya will go into the nephro part. She's with Amrita Hospitals, Faridabad, since the last 25 years. She's got this vast experience and her areas of interest are, up till you reach the stage, I'll continue. So areas of interest are multi-organ transplantation, peritoneal dialysis. As madam reaches the stage, I'm going to finish all the papers that she's got in national and international 120 publications.
Thank you very much. Thank you. Shall we start?
Yeah. Sure, ma'am.
Thank you very much for this opportunity to be in Surat. My association with this city goes back almost 10 years back when I was in Kokilaben. The first time I came for a meeting, and I would like to thank Dr. Sanjeev Vyas, who makes me come back here again and again. And I have seen the change that has happened in Surat. Yesterday I could not even recognize the airport. Thank you very much for inviting me here. For the next 20 minutes I've been told, okay, I'll quickly rush through a journey of a patient with a pointer. With a patient with CKD, and I come from Amrita Hospital, India's largest hospital now, and this is our ICU and the transplant rooms. Anybody who comes to Delhi, please visit us. The rooms, the transplant rooms are one of its kind with ante-rooms and special rooms and nursing areas, and you will learn. Many of you are building up your own hospitals. You can see how we can manage providing state-of-the-art infrastructure in our country. Next minutes I'll talk to introduction, diagnosis, definition, therapeutic options for retarding the progression of chronic kidney disease. We have a lot more now. Management, the complications. We always forget the symptoms. I think they are more important than the creatinine. Renal replacement I will not discuss because of short of time. And finally, briefly about what is most important for all of us here, preventing chronic kidney disease. There has been a significant worldwide epidemiologic change in the last 25 years. We all know we are all aging and our population is aging. The communicable disease mortality has come down significantly, but on the other hand, we have higher incidence of non-communicable disease. Type 2 diabetes has actually almost gone up 4 times from 1980 to 2014 all over the world. Hypertension is more than 1 billion on 2015, and all of you understand these two diseases are the drivers of chronic kidney disease. So hence the global burden has increased dramatically, and India is not as bad as Africa. The pointer doesn't work. We are somewhere in the middle in green. The blue countries are the ones who have very little incidence of chronic kidney disease, whereas the red ones, Africa, driven by many infections and their genetic makeup, have a very high incidence of chronic kidney disease. So why is it important to understand chronic kidney disease? WHO calls this as the silent epidemic of this century. Not only it brings the burden of increased number of end-stage kidney disease, but it also brings you the risk of cardiovascular mortality, premature death. People die much early if you have chronic kidney disease. And various studies in India, in fact, every out of 10, one has some form of chronic kidney disease, and all of us now in our practice know. A patient that comes to you, some relative or some friend has some form of chronic kidney disease. It's very common nowadays. And the symptoms I put on the other side, these are the early symptoms of itchy skin, swelling legs, puffy eyes, sleeping, difficulty in sleep, want to go and pass urine more, especially in the nights. And that is when the journey of a patient with chronic kidney disease starts, and he comes to your clinic and asks you, because people are quite aware nowadays that, doctor, do I have chronic kidney disease? And then it starts your job to find out, do they really have chronic kidney disease? And the diagnosis and definition of chronic kidney disease involves a rise in creatinine, which should be factored with the GFR, presence of urinary abnormalities, which could be protein or blood, or even radiological evidence of cysts or a smaller kidney or a kidney with hydronephrosis. These are all three, if they persist for more than 3 months, are called to be chronic kidney disease. It's important to know you can have chronic kidney disease with just urinary changes without any change in the creatinine. So that is where it is important for all physicians here to pick up chronic kidney disease early. So the diagnosis involves blood biochemistry. We all deal with creatinine. realizing the fallacies of creatinine as a chronic kidney disease is entirely a different talk. We are now in ICUs are looking at cystatin C as a marker of chronic kidney disease more frequently. Urine analysis should have a routine urine microscopy and analysis. Always have a protein creatinine ratio with us. There is an emphasis on urine albumin creatinine ratio, which actually picks up early diabetic changes. But overall emphasis should be with protein creatinine ratio, which gives you an idea of all forms of kidney disease. And then radiology can be a simple ultrasound, even going up to an MRI to find out subtle changes. This is the chronic kidney disease marker. And if you see, green is the stages, and we divide the stages based on GFR and on the proteinuria. So we have not only have stage 1, stage 2, stage 3, 4 and 5, but we have stage 1, A1, A2, A3. Similarly, stage 3A has A1, A2, A3. The A1, A2, A3 is on marking with albumin creatinine, less than 30, 30 to 300 and more than 300. The areas where it is red is the area when you have a very high risk of developing progressive chronic kidney disease, that is G4, A1, anybody with stage 4 with any proteinuria, or anybody with stage 3A with mild proteinuria, or 3B with moderate to severe proteinuria. All this group actually need to be referred to a nephrologist. Rest of them can be managed. The yellow and orange can be managed with the physicians in consultation with their colleagues. We all understand it is highly prevalent, 10% of Indian population. The next study which we have shows much higher. Silent, and majority of chronic kidney disease in our population is actually spread out in the early stages. So it's important that we pick them up early rather than late. We all know there is hardly any definitive treatment, and whatever treatment we have is expensive. This is a study from India. The first study, the Indian registry, comes with Dr. Rajapurkar, who is from Nadiad. The study started from there, and what has been shown is that almost 10% of the incidence of chronic kidney disease is about 151 to 232. That is about almost 250 people per million population in India has chronic kidney disease. So you can realize the number of people who have chronic kidney disease. And the SEEK study shows almost 17.4% of our population have some form of chronic kidney disease with the standardized ESR data. This is a study, a paper just published in one of the American Society of Nephrology journals, where we have worked with India's major NGO, that is the Kidney Warriors Foundation. You have to realize when we make a diagnosis of chronic kidney disease, it is not very easy for the patient. In fact, 30% are shocked, they have disbelief, and then another 16% go off to do homeopathy and Ayurveda, and some of them don't even go for any treatment. 21% of course goes for a second opinion, and that doesn't work out most of the time. It's only 22% who actually go for treatment, and of the total number, the 15% accept or go ahead for dialysis. But what we have not thought of is there is a major chunk of patients who actually develop psychiatric illnesses, depression, they become social outcasts and then just don't do anything else, leave jobs, etc. So it's important that we just don't emphasize only on creatinine, but also look into their psychological health. Now, what are the options that we have for our patients? We were saying even 10 years back, we would have said that we have very limited options, but we can now actually look for stabilizing the renal functions. Every single patient that comes to you with a high creatinine, please look for reversible and treatable chronic kidney disease factors. Now, we can tell your patients that yes, we can retard the progression, we cannot reverse completely, but can retard and then treat your complications and look for the comorbidity. These are the factors which I think all physicians will look. There are multiple reversible factors. Some of them involve the heart. Heart and the kidney go together. Look for heart failure, pericardial effusion, severe hypertension, use of nephrotoxic drugs. Somebody was talking about lead poisoning. Lead also leads to progressive chronic kidney disease. So we should always look for this. Presence of obstruction, presence of renal artery stenosis, malignant hypertension, hypercalcemia, malignancies, all of this causing chronic kidney disease should be looked for and treated. It's very salutary to see people with high creatinine being diagnosed and treated and let the creatinine come down. Many of them, like multiple myeloma nowadays, even go back to normal creatinine if treated properly. The retardation of chronic kidney disease has moved a lot forward now than what it was. Initially, we just used to talk of renin-angiotensin, aldosterone blockade, but we have other medications with us which has made a significant difference in retarding and delaying progression of chronic kidney disease. This is a slide which actually we don't have time to discuss RAS blockade, but RAS blockade helps both cardiac and renal involvement and has been consistently shown over the years to improve cardiovascular and renal outcome. There are a few areas which it can sort of have an unfavorable effect in cardiac. It's only maybe because of the hyperkalemia that it comes along with RAS blockade, but very soon in India also we will have drugs which can take care of your hyperkalemia so that you will be allowed to take these medicines longer and sort of help our patients both ways. These drugs have made a difference and they have made a tremendous difference in our country. We have multiple studies, the Emperor kidney being the latest ones. They can be used up to any level of GFR up to 15. So till you go to stage 5, you can use these drugs. And there are studies now with dapagliflozin these are the flozins, the sodium glucose transporters, T2 transporter inhibitors, and they have been used in any GFR and any level of proteinuria. So if you have a creatinine at 1.5 and no protein, you can easily use these drugs. They have been FDA approved not only for diabetic kidney disease, but with FSGS, IgA nephropathy. They have been considered for hypertensive kidney disease, but only thing is they should be used with optimal RAS blockade. What they do is the biggest poisons in our body, salt and sugar. Even today in SIP, when I was having my diet, I realized the load of salt and sugars are very high in our diet. This group of drugs makes your urine salty and sweet. So it tries to remove all the excesses that we get into our body and get them out and help retard progression. And there are multiple other factors which have been shown to benefit these groups of drugs. MRAs, finerenone is available in India, actually inhibits the aldosterone cascade pathway, also benefits kidney, heart and vascular dysfunction. In fact, the studies like Fidelio, Figaro and all have recruited more than 15,000 chronic kidney disease patients and have shown tremendous benefit, almost 20% improvement in the regression. So what we have, diabetes being the commonest kidney disease, is we have a set of drugs which include ACE inhibitors, SGLT2 inhibitors, non-steroidal MRAs like finerenone, and even on the other side, the GLP-1Rs, the glutides, the semaglutide, and all of them have also been shown, along with DPP-4 inhibitors, the gliptins, have shown to retard not only your hyperglycemia but improve kidney disease. So my plea to all of you is whenever you treat your patients with hypertension or diabetes, consider these group of drugs as your early armamentarium. And in fact, ADA has said that after metformin, the next group of drugs should be SGLT2-1, followed by the DPP-4 and GLP-1RA, depending on your cardiac risk profile. Now we come to the complications. We know kidney is just not creatinine removal. It removes your metabolic bone factors, but it is important that it maintains your bone. It helps you in your blood formation, removes your water and salt and maintains your blood pressure, recovers bicarbonate, acidosis, and most importantly, takes care of potassium. So when you have a chronic kidney disease, please address all these issues of your patients. So essentially what we treat is anemia, bone disease, besides of course retarding, nutritional intervention. Look for some certain areas which we are not very good at chronic kidney disease. Physicians, is we don't look at the vaccinations that they need, and sometimes we completely disregard their symptoms. Anemia has multiple factors, iron deficiency being the commonest one, folate, B12, erythropoietin formation is reduced, RBC survival is lost, blood is lost every time when you are on hemodialysis. But what has made a difference in anemia, what we understand now, all this is fine, but Still, if you replace iron to our patients, the hemoglobin doesn't improve. That is because of the functional iron deficiency our patients have. Because of the inflammation, the liver produces a peptide called hepcidin, and it does all kinds of wrong things. It does not let you absorb the iron. When it is absorbed, it doesn't let you go to the liver, and when it is going to the liver, it does not let you go to the bone marrow, so hemoglobin doesn't form. So we now have with us medicines which actually handle this problem with anemia, and that is this group of drugs. A little bit of mouthful, HIF-PHI, that is hypoxia-inducible factor prolyl hydroxylase inhibitor. They're available in India. In fact, Zydus is making it from our Gujarat, and these are oral medicines which actually take care of your anemia. Very easy to use, except for a few contraindications, very useful and very effective. You can do away with your, if you have iron deplete, you can do away with your weekly or even twice weekly injections. Bone disease management includes the hyperparathyroidism, calcium, vitamin D, and involvement of phosphate binder. In fact, bone disease is very complex. Please don't forget, these patients of ours used to be called renal osteodystrophy, but they have significant osteoporosis along with them. So when you're treating them, you're replacing their vitamin, you're trying to correct their hyperparathyroidism, you're cutting down their phosphorus. In the elderly people, get a bone mass densitometry, and if there is osteoporosis, you have to think of managing them depending on the type of bone disease. If it's a high turnover bone disease, then you use drugs like denosumab, and if it's a low turnover bone disease, then you think of teriparatide and other groups of. But osteoporosis is important, fractures are very common. Nutrition plays an important role, and this is very commonly known, and nutrition actually takes care of many aspects. The cardiac risk, the reduction of metabolic acidosis, phosphorus, etc. And morbidities are very important, because if you have cardiovascular comorbidity, and as the GFR drops, the risk of heart failure and coronary artery disease is also very high. This is the total symptom burden in chronic kidney disease. You'll be surprised how many symptoms our patients have, and we don't even look into it. The most important one is pain, which we neglect, and many physicians will tell you that because you have chronic kidney disease, we cannot get pain management. So this is the WHO step ladder pattern. Start with paracetamol, use adjuvants like gabapentin, pregabalin, tricyclic, move up to tramadol, tapentadol, and then finally, if the pain does not improve, you can always use opioid analgesics. But in this, there is no NSAIDs, unfortunately, but still you can manage with this kind of medicines. Pruritus is a very common symptom, itching. Start with optimizing dialysis if they're on dialysis. If they have hyperparathyroidism, think of parathyroidectomy. And then if it doesn't work, use local applications. Even just moisturizing agents help them. We have topical capsaicin in our country. Then later we move on to gabapentin, antihistaminics in the nights. There are the availability of kappa agonists like difelkefalin, which is going to come to India within the next year and may change the management of pruritus. When we reach managing our medical emergencies, we realize that we are reaching into a late of dialysis, and the electrolyte imbalances like hyperkalemia, hypocalcemia, acid base is bread and butter for us as the patient moves into the last stage of kidney failure, where you start having tiredness, nausea, vomiting, encephalopathic symptoms, cramps, all these symptoms, and then you offer them dialysis. The indications completely include is uncontrolled hyperkalemia, acidosis, fluid overload, pericarditis, encephalopathy, and uncontrolled bleeding. Then there are relative indications which impact your patients. So your nephrologist will be telling you when to use this. These are the three forms of RRT we have: peritoneal, hemo, transplantation. I wish we could offer a cafeteria approach to them, but it all depends on the clinical indication, the comorbidities, and patient's choice. But transplantation is limited. In India, we have almost 2 lakh patients going into dialysis every day. And the cost per dialysis in a hospital is about 4,000 rupees for the government. So what is most important is we should go to the first step of the journey, that is, doctor, how do I prevent our chronic kidney disease? And this is where I think all of you come through, and we need your help. Primary prevention is very important when we look into the blood pressure and diabetes. Secondary prevention, when we have already had CKD but retired now, we have medicines now. And tertiary, you think of managing complications. It's important to understand the earlier you manage them, the earlier you find out about them, the better it is. It's called the legacy effect. The earlier you start treatment, the longer these patients last and the delay in progression. The International Society of Nephrology, from whom I am part of, has been trying its best with its World Kidney Disease at looking at various stages of management of chronic kidney disease. First is start early, look at woman and child health, because the smaller that baby that is born, that baby is going to develop chronic kidney disease in the future. So the journey of chronic kidney disease starts from the womb, and we have to see that the mother is well nourished. Then you move with the government which takes care of you, develop a healthy lifestyle, prevent obesity, prevent kidney stones, then move and diagnose and treat hypertension and diabetes early. Then go for the comorbidities. Heart and kidneys are good friends. So when you take care of your kidneys, take care of your heart. And then be vigilant, avoid kidney injuries, acute kidney injury, your malaria, dengue and all will worsen your kidney findings. And take care finally of your kidneys. Thank you very much for your kind attention.
Thank you very much, ma'am.
Sorry, I was told 30 minutes, so I had to rush through this.
Okay. Then I think it's ended perfectly on time. You hurried the latter part for sure. Just one question from my end, ma'am. How often do you use Cystatin C in Delhi?
It's quite expensive. We use in our hospitals, and there are only 2-3 areas where we use it. One is a patient on the ICU. If he stays in the ICU, his muscle mass comes down within the 3rd or 4th day.
True.
Then creatinine is fallacious. Then you start saying, oh, kidney to improve ho gaya hai, bahut acha hai. But actually there is no muscle, so there is no creatinine. So that is one area. Second is liver disease patients, whom also we use creatinine, Cystatin C. And third, sometimes with pregnant mothers. They have such a major muscle mass, and their creatinine is always lower because of the hemodynamic instability, changes that you have in pregnancy. Because I'm sure all obstetricians
and
will...
they are referred to you for the protein in the urine?
No, they are referred to us mostly in the ICUs on protein in the urine, preeclampsia and all of them.
Okay.
So they come to you, their baseline creatinine was 0.7 and they have florid preeclampsia. And the creatinine at that time is 1.8, 1.9. That is actually not very high. It's a mother and the child's creatinine altogether.
Yeah.
So then Cystatin C helps you. We falsely make a diagnosis of AKI in them. And then it becomes a cycle.
Okay.
So some of these areas it helps. We have started using it. You can all use it. There are lots of labs coming up. So
Hey, like, the thing is the cost, man.
yes, we are at, see, how much does your creatinine cost?
150.
Mine is 250 or something like
आप
that.
दिल्ली के हो ना?
नहीं, दिल्ली में और भी ज़्यादा है, 600 sometimes or 400. But my Cystatin C cost me 1,000 rupees. But if you get a Cystatin C once and you tell this patient has no kidney disease, you save him the repeat daily creatinine
Absolutely.
that comes up happening with these patients.
True. And our Cystatin C is also cheaper. It's 900.
So then
Uh-huh.
you should look at your colleagues to see the factor. Most importantly in ICUs, they become so much. Lots of papers saying the longer the patient stays in ICU, creatinine is of no value to them.
True. Thanks a lot, ma'am. A big round of applause for her. It's a difficult topic, but she's taken it up beautifully
If you
well.
have recorded it, I want my introduction to be present there. So the first part of it, when you said, it was said the nicest way, sir.
So, should I take that as a compliment?
Very
or?
much, sir. I think
Okay.
stop like this.
No, because for once I was like CKD'd. Okay, whether you're taking me or giving me, I didn't understand. Okay, for Dr. Urmila Ben, a big round of applause, and I asked Dr. Neha Patel and Dr. Parul Vadgama. Okay, as they bring it across and the photographer is ready. Thank you. Thank you very much. There's an important announcement I have to make. We recently realized there's a small fallacy.